So let's assume after the investigative process, it was determined that further DCFS involvement is required. My name is Dr. Bob Foltz. I'm a clinical psychologist with the MD-Ed team and helped develop the VitalChild solution. And in this sequence, I'm going to be speaking as Jamie Potter, the CPS caseworker. So with the delivery of more services through DCFS, what you're looking at now is the Multidimensional Youth Assessment 360 and the resource library page. This is filled with all the different assessment and evaluation tools that you need for gathering the critical information related to treatment planning, monitoring of services, the real-time reporting that's so essential, and successful outcomes. So one of the reporting tools that we've created is the Integrated Care Passport. I want to emphasize that in developing the resource library, we worked hard to make it trauma-informed, child-centered, family-focused, and outcomes-driven. In developing our trauma history assessment, we wanted to make it consistent with the Trauma-Informed Care for Children and Families Act. And this includes 20 different areas of trauma exposure. And importantly, this form can be filled out by both the youth and the caregiver. The form that has been developed is developmentally informed, and that means that if a particular area of trauma is endorsed, immediately the person's given the option to indicate what ages it occurred. In addition to that, it also indicates if it was an isolated exposure to trauma or chronic exposure. Now, those matter a great deal because somebody that experiences trauma early in their life may respond very differently to somebody that may experience it in their adolescent years. One of the major reasons that we're emphasizing the use of the trauma form is that so often in the field, symptoms that a child may present with may in fact be trauma symptoms, but may otherwise be diagnosed as a major psychiatric condition like pediatric bipolar disorder, conduct disorder, all sorts of other anxiety conditions, major depression, but in fact, they wouldn't be getting the right treatment unless it's understood to be a trauma condition or a trauma response. We've also, as I mentioned, included the caregiver trauma form because what the science is now telling us is that the caregiver exposure to trauma in their childhood can also affect their ability to support and provide effective parenting to their child. Evaluating trauma is essential because understanding that as a critical piece of the clinical presentation means that you're going to be able to provide effective interventions when the child needs it for how long they need it. Confusing it with another psychiatric diagnostic condition is only going to delay their ability to respond positively to treatment. So next, throughout this evaluation process, I would be, as the case manager or caseworker, adding information to the psychosocial history form. Now, this form was developed after reviewing over a dozen psychosocial forms from agencies across the Association of Children's Residential Center and a wide range of different essential data points that they collect. Categories include medical history, mental health history, legal history, religious affiliation, a wide range of different variables. And importantly, information can be added to this form over time as more information is learned. Also, this form and this information can be shared across providers, so everyone doesn't need to collect their own forms and own source of data related to these different topics. The next form I would want to complete is the Family System Support Form. And it's important to note that it's not just the caseworker that can complete these forms, but others that are participating in the delivery of services can be involved as well, whether it's a social worker, other clinician. But the information captured within the Family System Support includes engagement in the community, access to community resources, access to transportation, housing stability, communication patterns, financial resources, and other variables. This really helps paint a picture of what other needs may exist in addition to the child that's struggling with behavioral or emotional issues. Next, in my discussions with Aaron, I realized that substance abuse could be an issue in his clinical presentation. So I would move to use the substance abuse evaluation form. This form quickly captures a wide range of different substances that Aaron could be using, patterns of use, the frequency, those who he may be using with, and also importantly, his appraisal of the risk associated with use. So after completing even this brief evaluation process, I realized that Aaron and his mom would benefit from outpatient services. The VitalChild Resource Library has many forms for us to monitor that as well. One form that I would be using once Aaron and his mother engage in treatment is the response to treatment form. This helps determine what is working and what is not. Variables included are related to psychotherapy, medications, and other services. As the caseworker, I would program the VitalChild system to prompt this data collection at regular intervals so we can closely monitor any improvements or deterioration in Aaron or his mom's response to treatment. But let's assume that increasingly intense treatment strategies have been used with limited success. Due to ongoing difficulties and educational problems, it's been determined that Aaron should be placed in residential care. With any new intake, we would want to use the Universal Intake Form. This is a very brief form that documents the event, precipitating factors, and also designates the staff that would have access to the VitalChild system. This form can be used whether the child is being referred to an inpatient stay, residential treatment, or any other change in placement. Now, as the clinician in residential treatment, I would immediately review the Integrated Care Passport. This is a real-time summary of information and would quickly and concisely inform the diagnostic information, trauma exposure, any medical concerns, medication issues. It would also highlight Aaron's response to treatment, so I could quickly see what hasn't been working in the care he's been receiving. Also, as the clinician in residential care, I would want to use a couple important forms at the beginning of treatment and then throughout Aaron's care. I would want to create a baseline understanding of his clinical presentation, and to do this, I would use the clinical rating scale. This scale has been developed to include multiple symptoms. They all have behavioral anchors, and they have the management recommendations as indicated for each symptom category. These are also strength-based ratings. Within the level of care indicators, it provides a description of optimal functioning or also if a child needs ongoing management of the symptom. An absence of symptoms is not health. The goal is not just to suppress symptoms, but to build the strengths and improve coping. So as Aaron progresses through treatment, these indicators would continue to show improvement. I would also want to use the multidimensional youth assessment when Aaron is admitted. This would create a baseline for us to understand clinical factors, educational performance, resiliency, and views of the treatment environment. Mike is about to explore this in more detail, but it's really important to understand that the MDYA collects data from the youth, parent or caregiver, and the agency staff. The youth voice and that of the parent or caregiver is integrated into all of the outcomes reporting with the MDYA. Mike, you want to take it from here?
Yeah, thanks, Bob. So I'm Mike Corrigan, one of the other psychologists on the team. And before we move forward on here, all this evidence, all this information that we're helping you collect, I just want to remind you it's stored in Oracle Service Cloud. It's encrypted going up, it's encrypted going down, it's encrypted while at rest. So it provides you with this real-time access and saving it safely in so many different things. But as you can see, from the initial risk and safety assessments to ongoing long-term case management across your systems of care, encompassing trauma treatment, clinical care, and much more, by strategically aggregating together all this information collected, VitalChild's designed to perform sound operational and predictive analytics. You know, because without a large collection of quality, formative, and summative data documenting the 360-degree perspectives of the youth, their caregivers, and the staff serving them, feeding these operational and predictive analytics, the chances or probability for making errors increases. And with VitalChild, we've configured it to reduce this type 1 and type 2 error and provide a wide assortment of automated information-driven recommendations for your workforce to consider. So far beyond informing a placement decision as to whether or not a child should be removed from their home, with VitalChild's quality data collection efforts being shared on one platform across your agencies and tailored to your state's unique needs, we can configure VitalChild, this resource library, to also provide your workforce with a platform to monitor the level of care provided, as well as recommended treatment protocols essential to documenting family first requirements and meeting CWIS expectations, and producing numerous safety alerts. Like you saw previously in the clinical ratings, if there was a suicidal concern, if something came up, it could send an alert to the staff connected to Aaron immediately. Now, before we get to the multidimensional youth assessment Bob mentioned, let's say during Aaron's stay at residential treatment, maybe it turned out Aaron, he has an unusual incident and where he's showing symptoms of abnormal behavior and trying to hurt himself. And this might be due to a drug use or withdrawal we weren't aware of. So if this was the case, an unusual incident form can be completed. And what this does is, a lot of states have to do tens of thousands of these a year. Some states don't even have unusual incident form in place right now. But what we wanted to do was automate this. And also, instead of a horrible incident taking place and your staff and admin finding out about it via the local news, once this is completed, anyone connected to Aaron's case, the facility, and if it's set to a severity level, the system basically can text or email, notify anybody who needs to be notified that this incident took place. A unique feature of VitalChild, however, is that our data can be used to keep a pulse on every child, and a great amount of this data can also be used to better inform and train your staff related to outcomes documenting the care and safety levels being provided in your facilities, foster homes, and homes being monitored. Now, this MDYA measures, our multidimensional youth assessment, the MDYA measures 4 predictive dimensions essential to better outcomes in child welfare. We developed these, multidimensional education developed these during our federal research with the U.S. Department of Ed, National Science Foundation, and Department of Justice efforts that we've done. And what we realized is facilities and homes caring for kids are relying upon some predictive dimensions. Dimension 1 looks at climate and environment. Dimension 2 looks at the youth well-being. Dimension 3 looks at behavioral risk factors. And Dimension 4, a very important one given so many kids aren't graduating, looks at in foster care and CPS aren't graduating, looks at educational and parent support. And underneath all of these, as you see the check marks, these are built through reliable and validated scales we developed. And adding these together, we create a dimensional index, and we're all about reliability and validity. But back to the report. The MDYA report shows you how we assess these 4 dimensions and provide you with a 360-degree analysis of your youth, parents, guardians, and staff, and how they're viewing the behaviors and environments where your kids reside. So this report here would represent all the kids, their parents, and the staff and views of those who've been in this residential treatment center over the past month or a quarter or a year, whenever you want to pull up the report, weekly even if you wanted. We can also drill down to look more closely at the scales comprising each dimension. For instance, if we drill down into the Dimension 1, we might find there's an issue in the facility with bullying and threats of violence, or maybe it's a trust issue taking place with the staff supporting the kids. We might also see a halo effect taking place where maybe the staff sees things differently than the kids or parents. But we can also drill down to look at each specific child and what their mean scores are for each dimension and the scale, as well as how their parents or guardians are feeling. So this same type of report can be automatically produced in real time for helping social workers, CPS, and foster agencies track the safety and care in foster homes or CPS homes being monitored, which is an essential ingredient to reducing crises such as children missing from foster care homes or children experiencing ongoing neglect or abuse. The MDYA can even be used to monitor juvenile detention centers and service provider treatment programs. So an administrator can use the MDYA report's dashboard to look more specifically at how different facilities and homes performance compares across agencies, counties, regions, or state levels. We can show you that in a full demo when you're ready. Going back to how's this information collected, we'll pull up the residential treatment MDYA, and it'll show you just basically it's a number of questions similar to the other assessments we're helping you with. Our belief in research documents, however, is that all the time and money spent treating and caring for kids will be much better invested, successful, if we can be confident these kids are living in a home or facility where they get their basic needs met, feel safe, and some sort of love and belonging. So these MDYA monitoring efforts will help reduce crisis situations and help you make more evidence-driven decisions related to the care, to the placement, and basic needs possibly still missing, and finding the answers to help kids get back home. In fact, a number of these pieces from the MDYA are configured to populate the risk scores that we use to help caseworkers, prioritize their clients, and also the safety scores we have in our foster care placement system. So as you can see here, the MDYAs are similarly delivered as the other forms you have seen, and this assessment, which utilizes these reliable and valid scales we developed during our federal research efforts, is what we suggest using as the ongoing outcomes monitoring tool for your kids, and also equally important for informing continuous improvement efforts within your facility and homes. And please also note, we provide trainings on how to use this data for continuous improvement efforts. So it's not just about looking at challenges. We want to show folks how to use everything they have and build on their strengths to overcome such challenges. A lot of this information could be really great at helping foster parents figure out what they need to do better. But for a moment, let's now imagine if in this scenario we find Aaron stabilizing on his drug use and mental health and trauma symptoms, but as a result, we now find that Aaron and his mother have to appear in court to determine if Aaron needs to be sent to a foster home before returning home. If this was the case managers, social workers, staff, and clinicians who have been working on Aaron's case could combine their collected findings into a judge's planning guide that complements the integrated care passport. This will allow the magistrate to have the information they need to make a more informed, evidence-driven decision. What the integrated care passport and the judge's planning guide would show is that after about 6 months in care, although Aaron has made substantial gains and remains stable, it is determined that his mother is still trying to stabilize the home and environment. And as a result, the magistrate comes to the conclusion that placing him in foster care may be the most beneficial step before returning home. And if this was the case, then they could complete the change of status form. This change of status form, similar to the intake form, is designed to be standardized and used across all agencies. So the reason we have designed many of the forms and tools this way is so that we can help you use this data to configure your quarterly and annual accountability reports. Everything we're collecting can be configured to populate whatever type of reports you need. And by doing this, we're able to simplify and automate these tasks for your data analysts and IT folks, thus allowing them to focus their attention and expertise to further explore what the operational and predictive analyses are telling you about certain strengths and challenges being experienced at different facilities, agencies, and counties. Because as we all know, due to the differing staffing challenges, resources available, and the different unique needs and experiences your clients encounter across your state, what works in a larger city in your state might not work in another city or town or rural county. So our goal is to give you the data you need to personalize the system for each agency, each facility, based on the recommendations that are in here to really help each agency get what they need. We hope this gives you a good idea on case management. Thanks for watching this video.